Imagine walking into a really glossy high-end clinic for what you're told is just a simple 10-minute outpatient procedure.
Right, like a quick fix during your lunch break.
Exactly.
Yeah.
And you're seeking relief from the agonizing just daily pain of menopause. So the doctor uses a laser, promises you this quick fix, and sends you on your way.
Sounds perfect, right?
You'd think so, but a few weeks later, instead of relief, you discover your vaginal canal has been permanently scarred, like entirely foreshortened to just 2.5 centimeters long.
Oh, wow. Yeah, that's catastrophic.
It is. You're left facing extensive physical therapy, dilator programs, just to try and reverse this severe, irreversible damage from a device that was supposed to heal you.
I mean, it sounds like medical malpractice from, I don't know, a century ago.
Totally.
But this is happening right now completely legally under under this very modern, highly lucrative guise of women's wellness.
Which is wild. So welcome to today's deep dive. We are looking at a massive stack of sources today. Clinical trials, regulatory warnings, medical ethics guidelines.
There's a lot to go through.
There really is. And it's all detailing this absolute explosion of transvaginal energy-based devices.
Right, the EBDs.
Yeah. We're talking about lasers and radiofrequency therapies being aggressively marketed to treat menopause symptoms and perform something euphemistically called vaginal rejuvenation.
That the industry is just booming right now.
Yeah.
And it sits at this fascinating, highly controversial intersection of cutting-edge tech, deeply vulnerable patients, and, medical ethics.
For sure. So we're going to cut through that glossy, high-pressure marketing. We're going to examine the very real, very sobering warnings from global health regulators.
Which are pretty stark, as we'll see.
Very stark. But the ultimate mission for today is to answer one vital question for you, the listener. When the clinical evidence is incredibly murky and the technology is outpacing regulation, what should informed consent actually look like for these experimental energy treatments?
Because it's definitely not what's happening right now in a lot of places.
No, not at all. Because as you'll see, a quick signature on a clipboard in a waiting room is not just insufficient, it's genuinely dangerous.
Absolutely.
Okay, let's unpack this. Before we can even talk about the ethics of consenting to a procedure, we need to know what the procedure actually does to the body, right?
Yeah.
Like, what are these lasers doing?
Right. So to grasp the mechanics of the devices, we first have to look at the underlying conditions they actually claim to treat.
Okay.
The primary one is genitourinary syndrome of menopause, or GSM.
GSA.
Yeah. So when a woman's estrogen levels just plummet during menopause, the tissues of the vulva and vagina can drastically change. They thin out, they dry out, and they lose their natural elasticity.
Which sounds incredibly uncomfortable.
It is. It can cause severe itching, burning, and incredibly painful intercourse. Clinically, they call that dyspareunia. And for many women, I mean, it's a debilitating daily reality.
And traditionally, the gold standard treatments for GSM are pretty localized, right? Like topical vaginal estrogen creams, targeted pelvic floor physical therapy, or, specialized hyaluronic acid moisturizers.
Exactly. Those are the evidence-based front lines. But recently, we've seen a massive surge in the use of energy-based devices marketed as this superior, high-tech alternative.
Right, the flashy new thing.
Yeah. And the sources detail a few different types. You have carbon dioxide or CO2 lasers, which are ablative,
Ablative means
meaning they actually vaporize the surface layer of the tissue.
yikes, okay.
Yeah. Then there are erbium-YAG lasers, which are non-ablative, meaning they leave the surface intact but heat the tissue underneath. And alongside that, you have radiofrequency devices, which use electrical currents to generate heat.
The biological mechanism here is just wild to me. The clinical literature explains that these devices are inserted into the vaginal canal, specifically to heat the delicate tissue to about 40 to 42 degrees Celsius.
Right. The clinical term they use for that is controlled thermal injury.
Controlled thermal injury. I mean, it sounds like an oxymoron.
It really does.
It is essentially burning or damaging the tissue on purpose. It reminds me of aerating a lawn.
Oh, that's a good comparison.
Right, like you deliberately punch holes in the soil and tear up the grass roots because that targeted damage sends this panic signal. It forces the lawn to heal, stimulates new root growth, and ideally, the grass comes back thicker and greener.
Exactly. And the theory here is that this heat injury induces tissue remodeling.
Okay.
The body rushes to heal the burn, stimulating the production of new collagen, a process called neocollagenesis. And theoretically, that restores elasticity and moisture to the vaginal walls.
Okay, but let me push back on my own lawn aeration analogy here for a second.
Go for it.
A lawn grows back thicker because it has water, sunlight, and a healthy bed of soil. If a patient is suffering from severe GSM, their vaginal tissue is already incredibly thin, frail, and vulnerable, specifically due to the lack of estrogen.
Right. The foundation is compromised.
Exactly. It's a biological desert. So isn't burning a desert, even a quote-unquote controlled burn, isn't that inherently counterintuitive?
Mm.
If the tissue lacks the hormonal building blocks to heal properly, doesn't that just invite rigid scar tissue instead of, bouncy new collagen?
What's fascinating here is that the clinical data is actually starting to validate that exact fear.
Really?
Yeah. While the biological theory of heat-induced collagen growth sounds, incredibly promising on a glossy brochure, the clinical reality is far more complex and unpredictable.
Because it's not a lawn.
Right. The body doesn't always lay down healthy, elastic collagen when it's burned. Sometimes it panics and lays down dense, fibrotic scar tissue instead.
Oh, wow.
This is exactly why organizations like that's the National Institute for Health and Care Excellence in the UK.
All right, big regulatory body.
Huge. And RANZCOG in Australia and New Zealand, they have explicitly stated that laser therapy is absolutely not the recommended standard of care for these conditions. The technology is vastly outpacing the actual clinical evidence.
And that massive gap between theoretical marketing claims and actual proven clinical safety, that's what triggered health regulators across the globe to step in.
Yes.
And this regulatory friction is exactly why the informed consent process has become such an absolute battleground.
Totally. The watershed moment happened in July 2018.
I remember reading this in the sources.
Yeah, the U.S. Food and Drug Administration issued a highly unusual, very firm safety communication. They explicitly warned against using energy-based devices for vaginal rejuvenation or for treating any symptoms of menopause, urinary incontinence, or sexual function.
The FDA did not mince words there. I mean, they stated flatly that the safety and effectiveness of these devices for these specific gynecological conditions simply has not been established.
Right.
And more importantly, they warned that using them could lead to serious adverse events.
Yeah. And
when you dive into the MAU database,
the FDA's public repository for reporting medical device malfunctions and injuries, yeah.
Exactly. When you look in there, the details are visceral.
They really are. A cross-sectional analysis of that database over just a few years found 45 distinct events reporting severe complications.
And we aren't talking about mild, transient discomfort or a day of swelling.
No, not at all. Patients reported chronic, long-term burning pain, permanent numbness, recurrent infections, and actual physical disfigurement.
The case studies in our sources show exactly what happens when that controlled thermal injury goes wrong. Like, there was one patient who, after 3 rounds of CO2 laser treatment, developed a crescent-shaped fibrous band right in the middle of her vaginal canal.
Just thick scar tissue blocking everything.
Yeah. The scar tissue had grown so thick it created a partial obstruction and a stricture.
And then there was another patient who suffered severe vaginal lacerations when she simply tried to resume intercourse a few weeks after the therapy.
Because her vaginal canal had foreshortened to about 2.5 centimeters long.
2.5 centimeters? I mean, due to fibrotic scarring.
Which is just heartbreaking. She had to undergo months of agonizing pelvic physical therapy just to try to undo the damage caused by the laser that was sold to her as a cure.
And those catastrophic outcomes are the risks. But, in medicine, we always weigh risks against the actual efficacy of the treatment, right?
Like if it cures cancer, you accept the side effects.
Exactly. If this laser were a miracle cure that worked 99% of the time, you might have a complex ethical debate about risk tolerances. But look at the clinical reality.
Yeah, let's talk about that.
In 2021, the journal JAMA published a rigorous, double-blind, sham-controlled randomized trial by Liz and colleagues.
Okay, wait, let's break down that sham-controlled aspect because it is crucial for a pain study.
It really is.
A sham control is essentially a physical placebo, so some women got the real firing laser. But for the control group, the doctors inserted the exact same probe, the machine made the exact same whirring and beeping noises, the screen lit up, but no laser energy actually fired into the tissue.
That level of blinding is vital because the placebo effect in pain management is incredibly powerful.
Definitely.
So they followed 85 postmenopausal women for 12 months, and the results were completely paradigm-shifting for the industry.
Tell me.
There was absolutely no statistically significant difference in symptom relief between the women who received the actual fractional CO2 laser treatment and those who received the sham treatment.
None.
None. No difference in patient-reported outcomes for pain, no difference in physician-reported outcomes when examining the tissue, and no difference in the actual histological biopsies.
Wow.
The physical placebo worked just as well as the $3,000 thermal burn.
Okay, here's where it gets really interesting to me. If the highest quality evidence, this rigorously designed JAMA study, shows this expensive laser treatment might not work any better than a literal placebo,
Right.
and the FDA is screaming that the risks include permanently shrinking and scarring the vaginal canal, how on earth are clinics legally allowed to sell this to the public?
Well, it all comes down to a massive regulatory loophole in how governments clear medical devices versus how they clear pharmaceutical drugs,
Yeah.
combined with how they regulate the practice of medicine itself. These CO2 lasers are officially cleared by the FDA for general surgical cutting and dermatology.
Ah, I see.
Yeah, a manufacturer proves the laser can safely burn off a wart or resurface facial skin. But once a device is legally sold and sitting in a clinic, a doctor has the legal discretion to use it off-label for other things.
So let me get this straight. A med spa buys a machine cleared for dermatologists to cut skin and then turns around and markets it privately for gynecological use inside the vagina.
Exactly. The FDA regulates the manufacturers. They can issue warning letters telling the company they cannot explicitly print cures menopause on the side of the machine.
Right. The company can't market it that way.
But private clinics, cosmetic surgeons, and med spas operate in this regulatory gray area where they can aggressively advertise these off-label procedures directly to you, the patient. They bypass the strict, decades-long clinical trials required for something like a new daily pill.
Because the government isn't stepping into the exam room to stop the doctor, the entire safety net just vanishes.
Poof, gone.
The only thing standing between a patient and irreversible scarring is the conversation that happens right before the procedure.
Yeah.
Which brings us to the absolute core focus of our deep dive today. Because these treatments exist in this regulatory Wild West, what should informed consent actually look like for these experimental energy treatments?
Well, if we look at the strict guidelines from the GMC, the General Medical Council, along with the Medical Defense Union and the British Association of Dermatologists, they lay out very specific, non-negotiable mandates for consent in cosmetic and elective interventions.
Okay, what do they say?
It breaks down into 3 pillars: the who, the what, and the why.
Let's start with the who.
The doctor who is actually performing the procedure must be the one to obtain the consent themselves. This is a critical ethical duty.
That makes sense.
But in many modern clinics, you see this task delegated to a clinic nurse, a receptionist, or a smooth-talking patient coordinator whose actual job is essentially sales and financing.
Oh, wow.
Yeah, and the guidelines explicitly forbid this.
I mean, if the doctor is the one wielding the laser, they need to be the one looking the patient in the eye and explaining the risks. You can't just outsource accountability to someone whose bonus depends on how many lasers they book that month.
Exactly.
Okay, what about the what? What exactly needs to be disclosed to the patient?
The doctor must explicitly explain the unknowns. Valid legal consent requires the patient to understand that the long-term safety and efficacy of this procedure are simply not established.
To say that out loud.
Yes, they must state clearly that it is an off-label use. Furthermore, under NICE guidelines, the doctor is legally and ethically required to offer less risky evidence-based alternatives first.
Like the localized vaginal estrogen or the pelvic floor physiotherapy we mentioned earlier.
Yep.
You know, imagine going to a cosmetic dermatologist because you have a dry patch of skin on your arm.
Okay.
The doctor immediately pitches you a highly experimental $3,000 surgical skin graft, but deliberately fails to mention that a standard $30 moisturizer would completely fix the problem.
Right, that would be insane.
But that is essentially what is happening when clinics frame the laser as a proven, definitive cure, while hiding the fact that a cheap tube of estrogen cream might resolve the issue with decades of safety data behind it.
And that raises an important question. Can a patient truly give informed consent under those conditions?
I'd argue no.
The medical ethics boards say no, too. Acquiescence when you don't know the full truth is not consent. It is coercion by omission.
Which brings us to the why. Why is the patient sitting in that chair seeking this treatment in the first place?
The guidelines mandate that the doctor must assess the patient's psychological needs and vulnerabilities. They have to differentiate the motivation. Is this patient suffering from functional, agonizing daily pain due to menopause? Or are they chasing an unrealistic, externally imposed cosmetic standard driven by vague, predatory marketing terms like vaginal laxity.
Because that marketing really leans into making women feel like natural anatomical variations are medical flaws that need tightening or rejuvenating.
It's awful. And if a patient is seeking a cosmetic fix for a normal anatomical variation, driven by shame or a partner's expectations, the doctor has an ethical obligation to manage those expectations.
Meaning they shouldn't just take their money.
Exactly. And if necessary, they must refuse to perform the procedure. You cannot ethically use an experimental thermal burn to treat a psychological vulnerability.
Okay, let's assume the absolute best case scenario.
Okay.
The doctor does everything right. They don't delegate the consent to a sales coordinator. They lay out the stark realities of the JAMA study. They warn the patient about the severe risk of fibrotic scarring. They offer the estrogen cream alternative first. And they ensure the patient isn't being driven by predatory cosmetic marketing.
A perfect consultation.
Right. Even then, the guidelines state the patient still shouldn't make their decision in that room.
Right. Because of the ultimate safeguard built into the ethics guidelines.
Yeah.
The mandatory cooling off period.
The Keogh Review into Cosmetic Interventions, which is backed by major surgical bodies like BAPAS and BAPRAS, states there must be a minimum of 2 weeks, 14 full days between the initial consultation and the actual booking of the procedure.
Yep.
You cannot have the consultation and the laser treatment on the same day.
And there's a good reason for that. Consultation environments, especially in private, for-profit clinics, are inherently high pressure. You are sitting in a pristine room with a confident, authoritative surgeon in a white coat.
Yeah.
You're looking at carefully curated, glossy before and after photos that only show the best outcomes.
And sometimes you're facing financial pressure too, expiring 2-for-1 package deals or, discounts if you sign the financing paperwork today.
Which happens a lot. But the guidelines specifically warn that financial pressure should never dictate the timing of a medical intervention.
Because elective, energy-based procedures are irreversible.
Right.
You cannot unburn tissue, as we saw with the patients who suffered severe foreshortening.
Exactly. The cooling off period physically removes the patient from that high-pressure sales environment. It is an active, vital period for the patient to go home, review the written summary, research the real risks on their own, consult their primary care physician, and ensure they aren't making a purely impulsive decision driven by the charisma of the clinician.
I am genuinely struggling with this guideline, though.
How so?
Well, if someone is sitting in a clinic in agonizing daily pain from genitourinary syndrome of menopause, if intercourse is impossible and just walking causes burning, isn't making them wait 2 full weeks to get relief actually kind of cruel?
I get that it feels counterintuitive, but if
Yeah.
we connect this to the broader principles of medical ethics, the waiting period is essential exactly because patients in pain are the most vulnerable.
Oh, I see.
Chronic pain makes people desperate. And when you are desperate, your ability to rationally weigh risks is severely compromised. You are highly susceptible to marketing that overpromises a quick fix and downplays the catastrophic risks.
The desperation itself impairs the ability to give valid consent if you're rushed. You just want the pain to stop, so you'll sign anything.
Exactly. The pause protects the vulnerable from predatory hope. It doesn't deny them care. It ensures their choice is truly voluntary, fully informed, and uncoerced by the desperation of the moment. It gives the rational brain time to catch up with the emotional desire for a cure.
So what does this all mean for you, listening right now? We have explored a complex, incredibly murky landscape today. We looked at the exploding trend of transvaginal energy devices, these CO2 and radiofrequency treatments promising quick, painless fixes for everything from menopause to cosmetic laxity.
Right.
We examined the stark, frightening contrast between that glossy marketing and the sobering clinical evidence, specifically the JAMA study showing it might be no better than a placebo, and the FDA warnings about severe, irreversible scarring.
But most importantly, we broke down how patients can legally and ethically protect themselves when the regulatory agencies cannot.
Navigating modern healthcare, especially in this highly monetized, rapidly expanding women's wellness space, requires you to be your own strongest advocate. Knowing exactly what a doctor is legally required to include in informed consent gives you the ultimate power.
Absolutely. If a clinic tries to have a receptionist rush you through a consent form.
Huge red flag.
Right. Or if the doctor doesn't explicitly discuss the clinical unknowns and offer you conservative alternatives like estrogen or physical therapy first. Or if they try to pressure you into skipping that mandatory 2-week cooling off period. You now have the knowledge to spot that glaring red flag.
You have the power to put the pen down and walk out the door.
It is entirely about shifting the power dynamic back to the patient. And as we wrap up, I want to leave you with a final thought to mull over.
Okay, let's hear it.
Think about the bizarre double standard in how we regulate medical treatments. If this vaginal rejuvenation treatment were a daily pill, a pharmaceutical drug, it would require decades of rigorous double-blind trials to prove it was both safe and effective before it ever reached a pharmacy shelf.
So true.
But because it's a device originally cleared for cutting tissue in general surgery, it bypassed all those hurdles to be used off-label in one of the most sensitive areas of the human body.
Which is terrifying.
Right. So, as medical technology continues to evolve exponentially faster than government regulation can keep up, will the burden of proving a treatment's safety increasingly fall entirely on you, the patient, and your ability to decipher the fine print of a consent form?
It's a terrifying thought, but it is the reality of the healthcare landscape we are living in. Stay curious, stay skeptical, and always, always demand the full truth before you sign.